just that. Oh,
there you are. So.
Recording in progress popped up when I was doing that.
Oh no!
I'm Jen Giordano, one of the endocrinologists at WVU.
Perfect. Thank you so much. And Kelsey Briggs.
Hi, yep, I'm Kelsey Briggs. I'm one of the pharmacists in the population health team.
Great. Thank you so much for joining us. And then I see a phone number pop up, 681-342-3859. Okay. Amy Sweeney, Population Health. Thank you so much. Excellent. Okay, I'm just going to go ahead and share my screen and pop up your didactic. And whenever you're ready.
Thanks, Elizabeth. So I'd like to just kind of review some oral therapies for type 2 diabetes today. And if you guys have any questions, I think you know me by now, please, use your chat function, or please just jump in at any time. This is meant to be more of a discussion than me really barking at all of you guys. So please just chime in at any point in time. So our objectives will be to list and describe the oral pharmacologic agents for type 2 diabetes. We'll touch a little bit upon the efficacy, the mechanism of action, the different classes, and a little bit about the benefits, advantages, and adverse effects of each agent. I'm not going to be giving a full comprehensive review. I just wanted to kind of briefly touch on things as a reminder and in an introduction. Also, there's some new agents on the market. So hopefully by the end of the talk, we'll feel a little bit more comfortable prescribing those things. Next slide, please. So the mechanism of action of oral hypoglycemic agents, as you can see here, this slide is really busy and it's not meant to memorize or review every single thing in depth, but I just really wanted to point out that the targets of hormones and the targets of organs are very different depending on the classes of hypoglycemic agents that we use. So we can target the brain with things like our GLP-1 receptor agonists, amylin, bromocriptine. We can target the lipid cells, or the fatty cells in our body. We can target the nephron, we can target the muscle, the kidney, the colon, certainly the liver, which with one of the most common ones, metformin, and the pancreas. And we'll try to go through those each in a little bit more depth and mechanism of action when we talk about each drug class. Next slide, please. So good glycemic control remains the foundation of managing type 2 diabetes. And certainly we want to use a patient-centered approach with each patient and with each pharmacologic agent. So in the real world, we're faced with things like financial limitations, insurance coverage, patient compliance. So some patients, maybe they don't want to take more than one pill. So we try to strategize with the best drug, but also really what our patients are going to be able to do. So besides patient preferences, which I think is one of the most important things to consider, we have to also consider the mechanism of action of each agent that we use and make sure that we're not overlapping our agents, the efficacy of each one, the cost, the side effects. Certainly, I think that we would all agree most people don't want to gain weight with their agents, and some agents do cause weight gain. And so being sensitive to that is also very important in diabetes care. And I know that you all know that as well. Other comorbidities, and we'll talk about patients that have type 2 diabetes, some of the comorbidities that they may also be facing, such as cardiovascular disease or renal disease. We have drugs now that treat diabetes and cardiovascular disease and renal disease. So we want to always consider those other factors to make sure that we use the best drug that could target potentially all of those comorbidities. And then Also, paying mind to the hypoglycemic risk is very important as well. Some of the agents really do predispose to hypoglycemia, specifically the sulfonylurea class, which we will go through in a little bit more depth. Next slide, please. Oh, so I don't know if are all of those like that, Elizabeth, or that's somehow an error. And when I just pulled it up, it's normal on my screen.
Just those two. I do apologize. I don't know.
Oh, okay. Sorry about that. I don't
It's
even
okay.
know how I would go about fixing that, because on my Mac, when I went through the slides, they weren't sideways.
You can use that. Elizabeth, look at
Yes.
the top, that little rotation where the little arrow is when you clicked on the picture. See in the middle of the screen on the right above A1c goals, a little over to the
Yes,
right.
I think over here.
Down, go down then from there. It's like a little half. It's where you can rotate the picture.
Oh, this one.
Yeah, you should be able to rotate it. If you click on that, yeah, and then rotate. I think it's the other
Come
way.
on. Does it want to?
Oh, well, thank you. I'm sorry for the inconvenience to you guys. I hope it's readable now, but basically I put this slide in so that we all understand, the typical A1c goal for adults greater than 18, adults age 18 to 65 is less than 7%. Now, there are new geriatric American Diabetes Association guidelines that do not have that stringent of control. And so you really want to take into account the patient's age as well. And 65 and older, depending on if the patient has comorbidities such as cardiovascular disease or cardiopulmonary disease, where we're placing them at a higher risk if we're driving down that A1c too low and predisposing them to, polypharmacy or hypoglycemia may be a higher risk. And so in those cases, I want you to just understand that the A1c goal is not a one size fits all. And you do have flexibility with your patients, or say that, you have a patient that's on hospice. I have a patient in the hospital right now on call who is going home on hospice. And so even in patients younger than 65, we also consider the patient, and a patient going home on hospice, I'm not going to control their A1c at less than 7% either. That's comfort measures. So it really needs to be tailored to each person. But I will say the reason why the goal is set in the majority of adults less than 7% is because that is a magical number in diabetes, where you can fend off the microvascular complications of diabetes if you have excellent control, meaning less than 7%. I often get asked the question, well, can I drive down my A1c to 5 or 6%? And my answer is always, if you can obtain lower A1Cs without hypoglycemia, which is defined as a sugar less than 70, and you're not having frequent hypoglycemia or any hypoglycemia, then absolutely. Our goal, if we think about what a normal A1C is prior to the onset of diabetes, it's roughly in the, the 4% range. So the closer that we can get to that without hypoglycemia, certainly you can target a lower blood glucose in type 2 diabetes. Next slide, please. Oh, Elizabeth, I apologize. I'm torturing you so much this week. I can't really see. There we go. So again, the approach and the management of hyperglycemia, this really speaks to the previous slide again. So I was saying kind of when you need to do more stringent control and less stringent control. So, more stringent on your screen, it's on the left-hand side, or more stringent on the left-hand side, less stringent on the right-hand side. And so those are factors for you guys to consider in your own, patient population. So what are the risks? What are the risks of the drugs they're on and overlapping risks? How long have they had diabetes? If a patient's had diabetes for 60 years, there is very little. I can say, you want the diabetes to be within relatively good control. But if someone's had it for a long time and they have every single complication of diabetes, they may be at more risk if we're very tightly controlling their A1C and driving them down to less than 7%, because, if they have retinopathy and they're blind, or if they have neuropathy, it's more of a risk to drive down their sugars too low. We briefly touched on the life expectancy. So patients that are, on hospice or end stage, we don't want stringent control. We talked about the comorbidities as well, any kind of vascular complications or neuropathy. We certainly don't want to cause, hypoglycemia or falls from vascular or neuropathy. So maybe a little bit less stringent. And the patient's attitude, their compliance, their efforts. Those are all things that we look at in guiding our A1C targets. Next slide, please. So treatment should be initiated when the A1C rises to 6.5% after 2 to 3 months of an attempt at lifestyle intervention, if they haven't had any A1C lowering. And so we try to really aggressively treat our patients and not allow kind of, a pattern of, well, let's try diet and exercise for 3 months, and then that turns into 6 months, and then that turns into a year. We really want to prevent the complications from diabetes. So if we really don't see that there's been an A1C lowering, then that's when you want to consider doing something about it. Not delaying therapy is very important to prevention of complications. Next slide, please. So again, monotherapy, lifestyle changes certainly is first line. We have diabetic education here. I think all of you most likely do have access to some type of diabetic education. Before, we've touched on, most hospitals offer free diabetic education. A lot of the times it takes place in like rec centers or in the basement of churches. So if you reach out to your local hospital, they may be able to have some resources for your patient to help with these, lifestyle changes that we're referring to. If the A1C rises to greater than 7% while on medication, or if the initial A1C is greater than 9, combination therapy with 2 oral agents or with insulin should be considered. And then we'll talk about the cardiovascular risk factors in the choice of the therapy that we use. Next slide, please. In patients with type 2 and established cardiovascular disease, therapy should begin with, we said, lifestyle management and metformin. Metformin is always our first line. We've talked about the ADA guidelines, and the ADA guidelines still do have metformin as your first line agent. And then you want to incorporate additional agents proven to reduce the cardiovascular events in your patient that has cardiovascular disease. Those agents would be the Sglt2 inhibitors and the GLP-1 receptor injectables. The focus of this talk is the oral agents, so I didn't put the injectables in this talk, but I did actually just add on, there's the first oral GLP-1 receptor agonist that I added on at the end of this talk. It was recently released, and we'll talk about that in a little bit more depth too. So those were the biggest changes to the ADA guidelines that were added in 2018. Since that time, there have been ADA guidelines updated and released pretty much each year. The most recent guideline was January of 2021, which we've talked about in our echo. And I think Elizabeth and Mitra definitely have the slides if anybody's interested in those as well. Next slide, please. So this is, again, another bit of a confusing slide, but I really added this because I wanted to give you guys resources on where to go in your own clinics if you find yourself wondering, well, what do I do if it's monotherapy? What do I do if I need to add on therapy? How do I add on therapy? And what's kind of the strategy? And so the American Diabetes Association, the ACE guidelines, the Endocrine Society, they all have great algorithms. I think, we touched on the fact that metformin and lifestyle management are always going to be your first line in red there, monotherapy. And then, you know, dual therapy, if you need to add on agents, I want you to always consider the agents that do have cardiovascular benefit. So in pill form, that's going to be the sodium glucose-like transporter, the Sglt2 inhibitors. And those drugs, I have each kind of drug we'll go through in separate detail in the following slides, but just as a kind of brief introduction, those drugs are called Giardians, Farxiga, Invokana, or the generic names are canagliflozin, empagliflozin, dapagliflozin. And so those drugs have been proven to have cardiovascular and renal benefits. And then triple therapy, again, if they have cardiovascular disease, you want to make sure that you're going toward those drugs that help with cardiovascular disease, and adding on, say they're on an Sglt2 inhibitor, you can consider triple therapy with the GLP-1 drug, which is an oral drug called Rybelsus. And let's get into kind of talking about each drug in more depth. So let's go to the next slide, please. And this is just another reference for you guys. It's not something I wanted to go through in depth, but these are the ADA guidelines. So in your clinic, I keep this in my clinic to teach residents and fellows. It's each class, and it tells you kind of the benefits on the cardiovascular system, the benefits on the renal system, and then when you need to be worried about the contraindications, or, you know, when we need to hold the drug or reduce the drug because of the GFR. So that's really just for your guidance. Next slide, please. So combination therapy, effectiveness meta-analysis suggests that each new class of non-insulin agents added to initial therapy in general lowers your A1C about 1%. It's variable per patient. This was out of the ADA. Next slide, please. So to review just the different classes of agents, we have the biguanides, the sulfonylureas, the thiazolidine diones, DPP-4 inhibitors, Sglt2 inhibitors, the glitinides, alpha glucosidase or bile acid sequestrants, dopamine 2 agonists, and then I just added on the first GLP-1 oral agent, Rybelsus, as well, which we'll go over. Next slide, please. I'm sorry. Does anybody have any questions or comments?
Are you going to talk about Farxiga more?
I can. Do you have any specific questions about it?
Well, it's about the recent indication about the chronic kidney disease, and so where you are at in terms of using Farxiga in your patients, those who have kidney disease or those who do not have kidney disease.
I use it constantly. I prescribe it like water very frequently in type 2 diabetes, because you have an A1C lowering benefit, you have a blood pressure benefit, a weight loss benefit, cardiovascular benefit. So if your patient has heart failure, it has an FDA approval for treatment of reduced admissions for heart failure. And the Sglt2 inhibitors also have FDA approval for treatment of renal disease outside of type 2 diabetes. So in a patient that does not have diabetes, these drugs have a proven benefit of treating renal disease as well. So
Okay.
yes, I write it all the time.
Okay. And they mentioned that we should not use it in diabetes people whose GFR is less than 45. But those who do not have diabetes, we can use it up to the GFR of 30.
Yeah. So with diabetes, I think you have a bigger risk of dehydration and a bigger
Okay.
risk of acidosis, because remember, your SGLT2 inhibitors come with a risk
Give me two.
of, I'm sorry, what's that?
No, I was talking to somebody else. Somebody entered my office.
Oh, okay.
Yeah.
Yeah, so
You
SGLT2,
complete it. You go ahead.
yeah. So SGLT2 inhibitors come with a risk of ketosis. And I think that risk is certainly greater in patients that are at risk for dehydration and uncontrolled diabetes. And so I think that it is worth noting, you know, what the GFR is, and if your patient does have type 2, and if it's controlled or not, or if they don't have type 2, because if it's uncontrolled type 2 diabetes and their A1C is greater than 9%, I usually do not add on the SGLT2 inhibitor until I've used other agents and potentially insulin as well to lower their A1C until they're at less risk of dehydration, because certainly I am also, you know, aware of precipitating ketosis. Like euglycemic DKA is one of the risks of SGLT2 inhibitors. That's because, you know, the drug overall, it can increase glucagon production, and it decreases, it can decrease insulin, but increase glucagon. So you can be at a higher risk of DKA with SGLT2 inhibitors. So I don't really start the drug until the patient has more effectively well-controlled sugars. And I think that that's where they're getting at with the GFR.
Thank you for the explanation.
Sure. So we'll kind of go through each drug in a little bit of detail. So Metformin, this is your biguanide. It works on your liver. And the advantages of this, it's your first line agent. It can lower your A1C anywhere from 1 to 2 points in percentages, excuse me. It can help with your fasting blood glucose. It has favorable effects on lipids, very, very low cost. It's generic. It's weight neutral. Some people do have some weight loss. Very little risk of hypoglycemia. And I will mention that if your patient has an intolerance to the metformin immediate release, don't forget about your metformin extended release, which many people do benefit from and tolerate much better than the immediate release. Next slide, please. So the mechanism of action, it helps with glucose metabolism in the intestine. In the liver, it decreases gluconeogenesis and the production or the breakdown of glycogen, fatty acid oxidation. And then at the skeletal muscle, it increases insulin-mediated glucose uptake. So you're basically utilizing your glucose and storing it. And this all decreases hyperglycemia in the system. Next slide, please. The disadvantages, you definitely have to monitor renal function with metformin. It should be stopped if the patient is going to have IV contrast mediated and can be restarted 48 hours after it's confirmed that they have a normal serum creatinine level. And then one of the biggest issues is the reduction in the drug's efficiency as diabetes progresses. So you may find that in patients who have been doing really well on metformin for quite a while, suddenly their A1C goes up and they really haven't changed their diet, their weight, their regimen at all. So just be mindful of that, because the natural history of type 2 diabetes is it's a progressively worsening disease. It's highly efficient when there is insulin production, but again, at the end stages of disease may not be as effective. Next slide, please. Some adverse effects. I think you guys probably are familiar with this. It's a common drug, but some of the biggest things are to just make sure the patient's not having diarrhea, nausea, and a lot of the times the patient's not going to come to you and say, oh yeah, I'm having severe diarrhea when I started metformin. I think more commonly is what I see is, I'll ask review of symptoms and the patient will have diarrhea, and it really won't be linked to the metformin. So just be mindful if your patient's getting colonoscopy and they're having diarrhea and it's really an unknown cause of diarrhea, that, you should just consider metformin being a cause. Rarely it can cause lactic acidosis and B12 deficiency. There's really no good guidance on when to check a B12. So I typically do that yearly in my patients and replete if needed. Next slide, please. So this is just a journal article for you all to show you that if you do have to go from metformin immediate release to extended release, the efficacy is very similar between both groups. So I've heard frequently, is metformin extended release or XR as efficacious as the immediate release? And yes, metformin XR is efficacious from this journal article. Next slide, please. Some of the contraindications. So the recommendation is if your GFR is between 30 and 45, that metformin needs to be reduced by 50%. So the maximum dose of metformin is 1,000 milligrams twice a day. And so then that patient would need 1,000 milligrams daily. If the GFR falls below 30, it can no longer be used. So discontinue with a GFR of 30 or less. And then caution and elderly, if a patient has liver impairment or if they're in acute heart failure, that's not the greatest time to also start metformin. Next slide, please. So sulfonylureas, these work to stimulate the release of insulin from the pancreas. Its place in therapy, second to third line agent, and I think that's mainly because of the cost. But as far as the benefit and the efficacy of drug, I would place it lower in therapy. If I had my way, I wouldn't use sulfonylureas at all. I don't like them very much as drugs, but I think that we are confined to having to use them in some patients because they're so cheap. Here you can see low cost. It helps with both fasting and prandial blood glucose. They do have the effect of weight gain, and the risk of hypoglycemia is higher with these agents. Next slide, please. So the way they work, they lower your plasma glucose by stimulating the release of insulin through binding to what's called the SIR1 receptor. That's the sulfonylurea receptor on pancreatic beta cells. And I'm not going to go through all the physiology. I put the pancreatic cell here in case you want to look at this in a little bit more depth. But basically, they stimulate the release of insulin. That's why, again, when we talk about these agents for type 2 diabetes, a lot of the time they rely on endogenous insulin production that's already made from your pancreatic beta cell. And that's how the sulfonylureas work. Next slide, please. Some of the disadvantages, because of the high risk of hypoglycemia, please use caution in our elderly patient population. Hypoglycemia can cause, falls, car accidents, coma. There's some multitude of accidents that I've seen from severe hypoglycemia. And you want to be mindful of those patients too that have worsening kidney function, because as your GFR falls, these drugs stay in your system longer. So the risk of hypoglycemia is potentiated. Caution in those patients with coronary artery disease, because if you're causing hypoglycemia, you can cause increased demand on the heart. So you want to avoid in patients that have cardiovascular disease. Certainly if somebody has a sulfa allergy, because these are sulfa-based drugs. And then caution and renal or hepatic impairment, which we talked about. Next slide, please. Adverse effects, the rash comes from sulfa allergies. You can have headache, nausea, vomiting, photosensitivity, weight gain, and hypoglycemia. Next slide, please. And it's contraindicated in patients prone to hypoglycemia. So I often see that when patients come to me, they can be on a regimen of insulin and sulfonylureas. Once a patient graduates to insulin therapy, I don't recommend using sulfonylureas anymore because that can potentiate the risk of hypoglycemia, because now you have two agents that can cause hypoglycemia, but also because, if your patient is requiring insulin, you're really not getting much out of giving a sulfonylurea. You're not getting much bang for your buck and lowering your A1C. So, I think stopping a sulfonylurea is what I would recommend when a patient is graduating to insulin. Next slide, please. So I can't read the top of this one. I hope you guys can, but this is the thiazolidine class. And the way that these work is they increase the insulin sensitivity in cells. And again, probably second to third line agent, mainly because of cost. And again, lowering your A1C. Think of most of the oral agents as lowering your A1C 1%, maybe 2%. Can help with fasting and prandial blood glucose, favorable effect on lipids. Not so great with weight gain. It can cause fluid retention, so not the greatest for cardiovascular patients or heart failure patients. And then there's a low risk of hypoglycemia with this class. Next slide, please. The mechanism of action of this drug is the TZDs act by activating what's called the PPAR, or the peroxisome proliferator activated receptor, which you can see over there on the left-hand side. It's a group of nuclear receptors, and through a series of, cascade of events, it basically works on your GLUT4 receptor, which you can see at the top of the cell, to cause glucose uptake and glucose utilization. Next slide, please. So one of the things about these drugs is they do take quite a while to take full effect, so 2 to 3 months. Avandia was linked to an increase in triglycerides and a higher risk of MI or CHF. That was detailed by Steve Nissen back in somewhere in the early 2000s, maybe like 2008. So Avandia was taken off the market. We still have Actos on the market, and I often get the question about bladder cancer on that, and I'll go through a talk in the next slide about, or a journal club in the next slide about that. And then the cost, it can be high. Next slide, please. So this was a meta-analysis of pioglitazone and the risk of bladder cancer. And the results showed that there was no difference in the incidence of bladder cancer among the pioglitazone group and the non-user group. And so the increased risk of bladder malignancy was they would hope that, physicians kind of look into other causes or other factors that may cause bladder cancer after this was published. Next slide, please. Adverse effects, we touched on this. So weight gain, liver toxicity, it can have increased risk of fracture. And then there's a black box warning on it. So in patients that have heart failure, we want to avoid this class. Next slide, please. Contraindicated if they do have liver disease, existing fluid retention from any cause, heart failure, nephrotic syndrome, and New York Heart Association class 3 or 4. So completely contraindicated. Next slide, please. The Sglt2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, these are called the sodium glucose cotransporter 2 located in the kidney. They blocks glucose reabsorption by the kidney and increases glucose going out. It's urinary excreted. And they do have a great cardiovascular benefit. Again, second to third line agent, and I'd say it's not used as much because we've certainly had coverage issues with it because it is one of the more expensive drugs. It can cause blood pressure reduction, helps with lipid profile. The efficacy is, again, about 1%. It can help with weight loss. And I think that the biggest weight loss benefit in that is because it's kind of like a fluid pill. So when you're excreting glucose, water is going with it. And so people can see it acts as kind of like a diuretic. So weight loss is great with this drug, and the blood pressure lowering is also great because remember, in our type 2 patient population, we really want blood pressure targets to be different and lower. The target in patients with type 2 is less than 130/80. So you can hit multiple birds with one stone with your SGLT2 inhibitors. The risk of hypoglycemia is very low with this class of drug, which is also wonderful. Next slide, please. The disadvantages requires renal adjustment. Certainly being attentive to the balance between the patient's other diuretics. So if they're on, metolazone, Lasix, or any other diuretic, you really want to be mindful because these drugs act as diuretics. And so in my own personal practice, if I see that a patient is on something like Lasix, and they've lost weight from this drug, I try to reduce their Lasix and see if they would tolerate it better with a reduction in Lasix. And a lot of the times that's just what they need, because this drug can cause orthostatic hypotension because it acts as a diuretic. So that's when, upon standing, you can feel lightheaded or dizzy. So by reducing their other diuretics that may not have as great of a benefit, we can use the SGLT2 inhibitors and max them out for their diabetes, their blood pressure, and their heart failure. And Lasix doesn't really have all three of those added benefits. So you can see there's a multitude of benefit from the SGLT2 inhibitors, and I try to frequently use them. I'm not a representative for SGLT2 inhibitors, by the way. I just think that they're really fantastic agents, and they have their place, though. We did talk about not adding them on when things are severely uncontrolled because the patient could be at higher risk for dehydration from uncontrolled diabetes. And just keep in mind the euglycemic ketosis. Next slide, please. So adverse effects, we talked about the hypotension, syncope. They can go to the bathroom more frequently simply because it's like a diuretic, like we talked about. Urinary tract and yeast infections can be seen. I will point out that in type 2 diabetes, there is a higher risk of urinary tract and yeast infections at baseline because type 2 diabetes, because there's more glucose around, infections like glucose. So patients with type 2 diabetes are overall at a higher risk for infection. You can see kind of a bump in the creatinine in the initial use of this, but over time that resolves. And then I have to apologize, but there used to be this FDA black box warning, and that has recently been removed. So I just want to clear up that the risk of amputations, you may have heard canagliflozin or Invokana had previously been associated with this, but that's since been removed because it was only seen in one study. They didn't prove that in studies with Farxiga or Giardiance. It was only seen with Invokana. And so they removed it as a class effect. And they've removed it with Invokana as well. And I have some data from Dr. Iannucci on that, if anybody is interested in learning about that a little bit more. Next slide, please. So it's contraindicated if a patient is end-stage renal disease, and it's these agents are adjusted depending on which agent you use, whether it's Giardiance, Farxiga, or Invokana, depending on the GFR. And the American Diabetes Association website, I kind of put all that stuff in the beginning, all those tables, because if you want references and you want GFR guidelines for each drug, you can find it in the American Diabetes Association guidelines, or simply, up to date as well. And then we talked about ensuring the patient's euvolemic and they're not dried out, they're not going to surgery. You want to make sure you hold these drugs prior to surgery, because that can be a risk of adverse events if we're adding on, SGLT2 inhibitors before they go in for surgery. So they need stopped 2 to 3 days before hospitalization. Next slide, please. So to talk about the DPP-4 inhibitors, these are gut hormones, and they prevent the DPP-4 enzymes from breaking down what's called GLP and GIP. They indirectly stimulate the insulin release from the pancreas, and they decrease glucagon secretion. They can slow down gastric emptying, enhance satiety. The advantages of this, again, second to third line agent, they can lower the A1c. They can help with mealtime blood sugar. They're weight neutral, and there's no risk of hypoglycemia with these drugs as well. So that's a great thing. Next slide, please. And we talked about this on the previous slide, but I liked this visual to help understand it. So the DPP-4 enzyme, so DPP-4 inhibitors, they block DPP-4. The DPP-4 enzyme is what inactivates incretins. And incretins are those gut hormones called GLP and GIP that are found in all of our own guts. And they work to stimulate insulin release and inhibit glucagon release and lower blood glucose. So the DPP-4 enzyme inactivates them. So we want to block that enzyme from inactivating them with this class of drug. Next slide, please. The disadvantages, again, most of our drugs, you'll see this is a common theme. A lot of them are renally cleared. So just try to always pay mind to your GFR when you're prescribing really any agent for diabetes. I don't even care if it's insulin. You know, this talk isn't really about the injectables, but any oral agent or injectable for diabetes, just be mindful of the GFR. One of the biggest disadvantages of this drug is the cost is high, and it doesn't really have a cardiovascular benefit. And that is really what we need in a lot of our type 2 diabetes patient population. So I don't feel that this drug I prescribe as much in my patient population. I see a lot of patients with severely uncontrolled diabetes, many complications, including coronary artery disease, heart failure. In your patient populations, though, it may be a different story. You know, you may have younger patients with type 2 diabetes who have no heart disease, who this drug would be great for because, you know, not everybody really needs insulin or injectables. And so to use an oral agent is ideal in a lot of patients. Next slide, please. So the adverse effects, you can have headaches, a lot of stuffiness or nasal congestion, I've heard. There is a risk of pancreatitis with these agents, and if the patient has a history of it, I don't write for it. There has been questions of heart failure and saxagliptin and allogliptin, and you'll also see that in the American Diabetes Association chart that I handed out to you. In the first couple slides, there's a section that says the cardiovascular effects of all of our drugs. And so if a patient has heart failure or cardiac disease, these aren't drugs that I typically recommend. They can cause increased elevation of LFTs, and it's thought that we should stop the drug if it's greater than 3 times the upper limit of normal. It can be related to irritable bowel, and then angioedema, skin conditions. I've even seen autoimmune kind of joint discomfort and those type of things like arthralgias. So just be aware of that. Next slide, please. So the meglitinides, this is like Starlix and Prandin. These stimulate the release of insulin from the pancreas. I don't feel like we write these as much in our clinic. I think they're older agents. And it's just because you have to keep up with this often. It's for every single meal. And so it's not as great for compliance purposes. It has an effect for weight gain. There is a risk of hypoglycemia, so using caution again in patients who are prone to hypoglycemia or in the elderly population. Next slide, please. The way they work is they act on functioning pancreatic beta cells. So that means that you are producing your own insulin still. So they bind to the sulfonylurea receptor. of ATP sensitive potassium channels. And basically, once again, they have a series of reactions to ultimately end in the release of insulin. They have a rapid onset and a short duration of action. So that's how they're different than the class of sulfonylureas, which they're frequently compared to. And they should not be used with sulfonylurea agents. Next slide, please.
Dr. Giordano, sorry to interrupt your slide presentation. We have about 12 slides left, and I just wanted to leave a little room for questions and announcements.
Yeah.
If anybody has any questions, then we can continue on, or if you have a specific slide, I can definitely make sure we get to that slide.
Yeah, no, I think what we could do is I can take questions, and then if anybody has any questions, you can certainly reach out to me about the remaining slides. I think would be a good way to go about it.
Perfect. Yeah, and I'll send your slides in the recap as well, or if anybody wants any more of that research, I think you mentioned Dr. Ionici or Nucci.
Yeah, Nucci.
Yeah,
Absolutely.
we can provide that to them as well. But we do have one question. Says, what is a lab that assists with beta cell function?
Okay, so a specific test that you can look for beta cell function, if you're trying to differentiate if the patient's making their own endogenous insulin, is to check what's called a C-peptide. C-peptide is a cleavage off of our own insulin. So if you have a normal C-peptide level, that means that you are making insulin. If the C-peptide is undetectable or absent, you're not making insulin.
Amy, I see that you unmuted. Did you want any further discussion about that or questions? She says, is there a range that you look for before prescribing?
You know what, Amy, could you clarify before prescribing, do you mean insulin?
I think she's only able to chat in, so I'll just wait for her answer. GLP-1s?
No, so I look for the C-peptide when I'm trying to distinguish between type 1 and type 2 diabetes. Type 1 is the autoimmune condition where you have destruction of your pancreatic beta cells and you should have 0 C-peptide. Your body stops making insulin. There can be an exception to that. There's like a honeymoon period where when you're first diagnosed, you can still have a trickle of your own insulin, but over time that burns out. But I'll look for the C-peptide in those cases. We also look for antibodies in those cases. So the antibodies are like the anti-islett antibody, the zinc transporter antibody, and the GAD antibody. And those are really what I look for when I'm trying to determine, you know, do I want to write oral agents and GLPs for a type 2 patient? Or is it type 1 and they should only be treated with insulin? Does that help, Amy?
Yes, thank you so much. Thank you for the question, Amy, as well.
Great.
Does anybody else have any questions? I can provide it in the chat. Use the raise hand feature that we have under your reactions, or if you want to just unmute yourself, that is completely fine as well. Can someone, this is a question I just thought of, can someone go from injectables to oral, and then are they most likely going to go back to injectables because it progresses and gets worse as we get older?
Yeah, absolutely. So diabetes isn't as simple as saying type 1 and type 2, and I don't mean to downplay it to that. There are many forms of diabetes. Type 1 is the autoimmune form. There's forms called LADA, which is latent autoimmune diabetes, like later onset, that has kind of an in-between picture of type 1 and type 2. There's pancreaprivic diabetes, which has kind of the characteristics of type 1, and that's where, you know, you can have recurrent pancreatitis or cystic fibrosis that can prevent exocrine function from your pancreas. And so those patients present with like complete insulin deficiency sometimes as well. And then there's type 2 diabetes where you have insulin resistance that can burn out over time. You know, you can lose your insulin over time, and that can take on the characteristics of type 1 too. So patients can be treated on orals and do fine their whole life, or sometimes patients can progress to the point where oral therapy doesn't help and they may need to graduate to insulin therapy. And a lot of the times, if they graduate to insulin therapy, it's not always reversible and we can go back to orals. And that really just depends on what the cause is. If it's the underlying natural history of their disease, then usually we don't go back to orals. If it's something like COVID infection and they were doing great on orals and then they get COVID, or say they get really high doses of steroids for treatment of COVID or treatment of a rheumatologic disease or something, and it exacerbates their diabetes and they need injectables temporarily. And then we can maybe go back to orals when those things improve and resolve. So I tell people when I start them on insulin that it's not a life sentence. You know, with type 2 diabetes, there are factors that can be improved, you know, diet, lifestyle factors. If they are on steroids, trying to wean or limit the steroids so that we can hopefully limit or wean insulin and try to go back on orals. So, you know, it's very complicated. And I just tell patients that not always, if you're on insulin, does that mean a life sentence of insulin. Now, type 1 is a different form of diabetes that is only treated with insulin. So in this talk, we just focused on type 2. So I just want to clarify, in type 1 diabetes, there is no role for oral agents or pills because they don't make their own insulin.
Thank you so much. Yeah, it's a very complex, complicated disease for sure. Does anybody else have any other questions before I make a final announcement? All right, if not, thank you everyone that was able to join. Our next session will be June 9th with Melissa Phillips presenting on insulin pumps. Again, I'll have that recap out to everybody and have a great rest of your day. Thank you.
Thanks, everybody. Have a good day.